where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning and welcome to Euronurse. I'm your host, Vic Senese. Glad to be here. Hope you guys all were able to survive the storm that came through and kind of a lot of damage. I live in Northwest Indiana and we got just hammered. We lost power early Tuesday morning and actually just got restored yesterday. So it's been really kind of a scramble trying to get through all those days without electricity, but we survived. Hopefully you guys survived it too. Hey, remember to like and subscribe if this is your first time checking us out, especially. And today, join me for an engaging educational discussion featuring renowned dermatology experts David Cotter and Naiem Issa. Together, they're going to explore the latest evidence-based approaches to diagnosing and treating genital psoriasis while emphasizing patient-centered communication and individualized care. Hey, and remember, this one is worth 0.75 contact hours, so be sure to fill out to obtain those at the end. It'll be on our website. You just click on what you need to do that. And let's get going.
Derm webcast. This activity, The Hidden Impact, a patient-centered approach to assessing and treating genital psoriasis, features board-certified dermatologists, Dr. Naiem Issa and Dr. David Cotter.
Hello, everybody. It's a pleasure to have you with this new discussion on a very interesting and impactful topic called The Hidden Impact, a patient-centered approach to assessing and treating genital psoriasis. I am joined today by my good friend, Dr. David Cotter from Las Vegas, and it gives us both great pleasure to be here with you to be able to talk to you about this wonderful topic. So before we get into introductions, right, tonight's learning objectives are going to be 1, identify the importance of full body exams and proactive communication in overcoming diagnostic challenges for genital psoriasis. In addition, we will assess the psychosocial and sexual health impact to provide a more comprehensive and patient-centered care. And lastly, we will critically evaluate the efficacy and safety of existing and emerging topical therapies. But before we get into the topic of genital psoriasis, let's first make some quick introductions. My name is Dr. Naiem Issa. I'm a board-certified dermatologist who works in Northern Virginia and also have faculty appointments as professor of dermatology at the University of Miami in Miami, Florida, as well as George Washington University. And here with my friend, Dr. David Cotter.
Thanks for the welcome introduction, Dr. Issa. Always a pleasure to chat with you, especially about such an important topic. My name is David Cotter. I'm a board-certified dermatologist practicing in Las Vegas, Nevada at Las Vegas Dermatology, where I serve as the director of clinical trials. And I also have faculty appointments at the University of Nevada School of Medicine in both Las Vegas and Reno.
Thank you, David. And as always, it's a pleasure to have you. And for some reason, I think my long hair is not showing in tonight's video. So we'll have to go back and edit this. So with this great introduction, all right, so let's first go ahead and get into the diagnosis and clinical presentation of what I think is a really challenging topic and often overlooked. Wouldn't you say?
Absolutely. It's such an important issue to address because I'll tell you what, if we don't proactively broach the conversation, it may be not just underdiagnosed, but also undertreated, which, as we'll get into tonight, can have incredible quality of life impacts for our patients to have undiagnosed and untreated genital psoriasis.
Absolutely. So that actually segues very nicely into just looking holistically at what the problem of genital psoriasis is, right? And as you said, it is a very underdiagnosed condition or subcondition, if you will. So statistics have shown that approximately 63% of all psoriasis patients will actually develop genital involvement. And that's such an interesting figure for me, actually, because that's a lot higher than I initially anticipated. What do you think about that, David? Do you think that number's accurate?
I completely agree with you. And it goes to show you that even in clinics like yours and mine, we underperceive the burden of genital psoriasis. And a lot of that goes to underreporting. Sometimes you have to build quite an extensive rapport with your patient before they'll feel comfortable even talking with you about it, even when we do bring it up. But you take that 63% number and you turn on its head, that means patients are more likely to have genital involvement than not have genital involvement. Essentially, 2 out of 3 will have genital involvement and 1 out of 3 won't, which means if you're playing the odds, you can bet that your patient has psoriasis in the sensitive areas.
And why do you think it's important, besides the fact that it's on that particular sensitive location or high impact site or sensitive area, as we could tend to call it these days, but is there any like particular associations that we may know of, like from a disease awareness standpoint, or is it just that we have a painful condition or an itchy condition, on the skin there? Do we have any insights?
Well, certainly, just like our patients that have scalp and nail involvement have an increased incidence of psoriatic arthritis, the same is true for genital psoriasis, where it essentially doubles the risk. But even beyond that, thinking about comorbidities like PSA, I also think about the quality of life impact. You might have 1% body surface area, but if that 1% is on your penis or your labia, it's going to have a much larger impact on your quality of life than even a patient that has larger BSA and extragenital sites. Therefore, it impacts how we may choose to treat these patients long term.
Absolutely. And actually, this is very interesting. Like the association with psoriatic arthritis, do we have any insights from a mechanistic standpoint as to why? Can we hypothesize why there's such a link?
That's a great question, except for, tongue in cheek suggesting that, some patients keep their hands down there more than they probably should. I don't know, Dr. Issa. What would you hypothesize?
Yeah, so it's interesting because I was, looking into this the other day in terms of, to me, initially, low body surface area connecting with more systemic joint involvement. There was such a, disconnect for me from a pathophys standpoint at first. But when so for example, let's say you take nail psoriasis, right? With nail psoriasis, we have a higher concordance with psoriatic arthritis of the distal interphalangeal joints, DIP, PIPs, and so on. But that nail apparatus has a local inflammatory milieu, if you will. But when you think about scalp or genital, like, well, what joints are being involved there? How do you get from scalp or genital to hands and feet or the axial system? One major hypothesis has been that you get a lot of Kebnerization because of trauma. And as you said, regardless of it being tongue in cheek, right, is that with trauma, however we see that trauma or get there, right, is that you have this Kebner phenomenon where you have this pro-inflammatory traumatic loop that may be spilling that inflammatory, cytokine milieu into the systemic circulation. And in my mind, that makes sense. And because of that link, I think it's also very important that we ask our patients, early for that reason, not just for their quality of life from the standpoint, of having genital involvement, but also, as you were saying, for the other extracutaneous effects of psoriasis, right?
No, you're absolutely right. And it's very interesting. And it's an important call out that even in psoriatic arthritis trials, what we end up seeing are patients that have incredibly active PSA, but are typically low BSA types of patients. And they're not normally what we might think about seeing in our psoriasis clinics. You see someone walking with 20% BSA, you think, oh my gosh, they must have a lot of bad things going on like PSA. But when you actually look at the demographics for PSA trials, you see that often it's a lower BSA despite having a very high number of tender and swollen joint counts. Right.
Those are some great numbers and very impactful, right? So interestingly, we have a delay in the diagnosis, as you've already said, approximately 2 to 5 years, so nearly half a decade, from onset, of having some cutaneous manifestation to the diagnosis, and that, our discussion really lends to why. So we won't, beat that horse, right? And then, as you said, about less than half of these patients actually report their symptoms to their provider, and I think there's an angle here for really connecting holistically with our patients and building that sort of safe space and shared decision making in terms of allowing that discussion for the patient, right? So I think we have to build that rapport, just like anything else in medicine, but in this particular topic, right? And David, so you also treat acne, I'm assuming, right, as a Las Vegas dermatologist, right? But
every once in a while.
Every once in a while, right? Now, the thing is, I see a analogy with acne, right? So bear with me as I take this through. We treat facial acne and we treat truncal acne, all right? And interestingly, a lot of clinical trials had focused on facial acne for good reason, but truncal acne had been a unmet burden for similar reasons, such that patients or patients' parents may not bring up the truncal involvement, or they'd be too shy to show those areas as well. But we are getting past that, right? We're becoming more culturally sensitive and such. And I think with genital psoriasis, we're at the beginning of that journey, and we hope to get to where truncal acne became more accepted. And I think we need to do better here, but I think we're at the beginning of that.
Yeah, absolutely agree. Well said.
Wonderful. So looking at some main key reasons for underdiagnosis, right? So you'll see we're repeating some core concepts here, but let's go ahead and dive a little bit deeper. So on the left side of the screen here, we can see patient barriers, right? And some, common thoughts here include embarrassment and stigma because, it's the genital area and having such symptoms. There's fear of the patients for disclosure during a physical exam for a variety of reasons. And furthermore, there's a potential assumption by the patient that these symptoms may be unrelated to the known psoriasis. So that itch that they may have, they think, okay, maybe it's an allergy, for example, to the dye that they may have in the underwear, and so on and so forth, right?
Yeah, these are spot on. Definitely patients are sometimes nervous to talk about it and definitely to disclose it, especially when you have discordant gender roles. You may be a male physician and a female patient and vice versa. I certainly see a lot more young men with penile psoriasis than young ladies with labial and vulvovaginal psoriasis, perhaps for obvious reasons. I mean, I do call myself a derm bro, but I love this third one. It's just the patients have been told it's not psoriasis. This is a yeast infection or this is eczema. And we kind of think about that in our world as derms. Well, you're not going to have psoriasis and eczema, although we could have a whole seminar dedicated just to patients that have overlap of these diseases. But what happens is patients just assume it's something else. And they've been told for years by their primary care physician, it's something else. And they don't even think to bring it up. But beyond the patient barriers, just like you've outlined here very nicely, there are absolute clinician barriers as well. And sometimes that's the omission of a genital skin exam in just a routine psoriasis or even skin check visit. And then furthermore, even if you do look, sometimes the morphology is atypical. If all you've ever seen are elbow and knee plaque psoriasis, you may not be attuned to making the diagnosis in these sensitive and inverse areas. And that can ultimately lead to confusion, even on the clinician side, with other diagnoses such as candidiasis, lichen sclerosis, Zun's balanitis, so on and so forth.
Right. Do you have any tips for us clinicians for how to approach the genital exam, especially, given our cultural sensitivity these days? I may not be a derm bro, right? But it's pretty obvious that I may be a derm dude, right? But, so approaching this, or maybe our derm dudettes for that matter, right? How can we approach, do you have any tips on how to engage that conversation and set the stage?
I'm very simple and straightforward. When I'm seeing a patient for psoriasis, particularly a new patient, I always mention sometimes this disease affects other areas that you might not normally think of. For example, often it'll affect the private parts. And then I'll pause and I'll tell patients, is that something you think you might have going on? You don't have to show me, but if you think it's something that's worth mentioning, we can talk about it. Because maybe they want to tell you, yeah, I do have something down there, but I don't want you looking. Or maybe it'll plant the seed. And when they come back for follow-up, they'll say, you know what, doc? Actually, yeah, I do have it down there. Can you check? Other times, Dr. Issa, I'll say, sometimes you have it on the backside. And people don't even know unless you look. Do you mind if I check? And usually when we're looking on the backside, especially, guy to guy, they have no problem. We'll take a quick peek and we'll find some psoriasis in the gluteal cleft. And that's a great clinical pearl that I like to have as a tiebreaker. If I'm looking at someone and I'm not sure if their disease fits perfectly for plaque psoriasis, I'll look for some of these other special site involvements. And I'll look in the gluteal cleft, for example, as a tiebreaker to see if I see psoriasis there.
Oh, that's fantastic. I'll add one additional thing. And sometimes, my patients, and I guess all of our patients, may be hard to please these days, right? They're demanding more of our noggins, right? because they can chat GPT pretty much anything, like while they're even in the room with us at the same time. But in order to convince them beyond artificial intelligence. So one thing I found that really resonates, at least in my clinic, has been that I do bring up the association with potential psoriatic arthritis, where basically time equals joint, right? And I do say that, well, maybe the rest of your body it looks fine and what have you, but if we are missing these sensitive areas, such as your genitals, we may be missing an important link, and I wouldn't know what's going on unless you show me, right? And then if you do happen to have that, then I can catch this condition early on, and I could probably save your joints. And that kind of changes, the air, in the room. And I have a pretty good hit rate, with that, and patients wanting to reveal, that anatomy. So I would just add
Great tip. Great tip.
Thank you. So speaking of that anatomy, right? So the anatomy is a little bit complex, beyond, labia and glans penis, right? This is an environment that's, is going to be dark and moist, right? And because of that, the classic morphology is kind of at the door, actually, with genital psoriasis, right? And that gives us kind of a broad differential diagnosis, and we're going to show some pictures in a moment once we navigate past these slides. But with this moist environment, right, you don't have this classic appearance, right? And then you will obscure, right, the classic diagnosis. So when things are moist, right, regardless of where they are on the body, right, if you have a typical scaling appearance, right, what happens to that scale, right? The scale goes away.
Fades away. Yeah,
right.
It's gone.
And what are you left behind? Whether you're Caucasian or Fitzpatrick Sticks or skin of color, what do you see?
Sometimes just a moist erythematous thin plaque. It can be really difficult to differentiate from other diseases like Zunes, and even sometimes seborrheic dermatitis can look very similar in these sensitive areas.
That's outstanding. I love that you brought up seborrheic dermatitis. We're actually gonna hold on that, and we're gonna look at it when we look at some pictures, because I find that there is certainly an increase of psoriasis or SIBO psoriasis in genitalia. And before, actually, I wasn't really looking and asking for that in my itchy patients in those areas. But now, just searing into my mind, some following images, I'm really catching a lot more of that, and I think that's a great pearl for everybody who's listening in. Right. So, again, so looking at the full body exam, right, as we're conducting this, we should, as you said, look at the genital and perianal areas. Dr. Cotter, I really love what you just said about looking at the perineum there. It's going to be that extra clue, to look beyond as well. And so just make sure that you're getting the patient's consent. It's always really important, right? Like whether it's verbal or written, just make sure you're documenting that you have the patient's consent. And I personally always have a medical assistant in the room. I never do these checks solo by myself. It's always, I think, it's very important for the comfort of the patient as well as for the comfort of the clinician and the team. And as you're doing your inspection, I would put on some gloves. I will move around the labial folds. I will move around some of the pannus if we have a pannus there to look into the inguinal creases, right? If the patient who's a male who is uncircumcised, I will actually pull back, while wearing gloves. Or if the patient is more comfortable to do it himself, I'll ask him to pull back himself. And sometimes just the act there will tell us a little bit if this painful, just really, like how eroded, right, and then how severe that impact is, right?
Especially if it's a patient that has maybe a touch of lichen sclerosis, we're still sorting it out. And sometimes it can be a little discomforting to do that. But I do agree, it's important to have patients retract their foreskin and inspect the glands, however you get there.
Right, absolutely. But as you said, so again, so it's the art of the medicine here, right? And that's exactly what the point of our discussion, right? So we have to get to be able to inspect and visualize, right? That's the main point. And while you're doing that, don't forget your other high impact areas, as we talked about, the nails, the scalp, as well as the joints, right? So
I'll throw in another clinical pearl here, and it's more of a pitfall to avoid. It's something I see often when we have trainees rotate with us, not particularly in this arena, because a lot of times patients don't want trainees in the room for a genital psoriasis exam or any genital exam for that matter. But I've seen younger clinicians like to offset an uncomfortable situation with humor. That is a major pitfall in this arena, because whatever you might think is humorous to you, when it has to do with someone's genitals, it just never lands right, which means this is not a joking area. Even though you may feel uncomfortable, the best way to address it is with the utmost professionalism and empathy, but don't try to lighten the situation with a little humorous levity, because more often than not, you'll miss the mark and actually offend someone and maybe, create a negative patient encounter.
Absolutely. Absolutely. That's a fantastic pearl, actually. So I hope our audience heard that. And even though we don't have it written in the PowerPoint here. So thank you. And that actually lends itself well to this concept of shared decision making, right? So even the American Academy of Dermatology, the National Psoriasis Foundation guidelines, right? They do recommend that we involve the patient, just like anything else that we do in medicine, right? Is to involve the patients in developing, diagnostic as well as treatment goals, right? And as you just said, this is not a moment of levity, right? This is a moment of professionalism, right? And gaining that patient trust and rapport. So thank you for that. So now we are actually going to look at some lesions in the genital areas, right? So here we're looking at female patients, and actually, and Dr. Cotter, let me go ahead and just pass the floor to you, right? Because you already started off our conversation and telling us about, like, you have, a wide differential diagnosis and how lesions may look different simply because of this area. Walk us a little bit about what we see on the screen here and how your mind goes through the diagnostic process.
Well, my first consideration when I see these two ladies and their labia here that are, very, very inflamed, I'm immediately just feeling sad for them, because I'm wondering what their quality of life is like and what's brought them to this point that they're finally coming to see me here and now. Maybe there's some ambiguity about what they have. Maybe they know what they have and they're finally ready to accept help. But generally, Dr. Issa, there's been a story up to this point, and they shared it with us about everything they've gone through. And then you're doing the exam and you're being sensitive. And we see some erythematous plaques, some that have more scale than others. And particularly the larger image on the right, we see almost what I kind of call like a beefy red plaque, but clearly that's a buzzword for Canada. And this is not Canada. This is dry. There's no satellite pustules. This is absolutely genital psoriasis. And this particularly is a patient that I would ask before touching, is anything uncomfortable? Is anything sensitive? It's a very good photo that captures, I think, a very severe case of genital psoriasis. And we talk about genital psoriasis as we get into the IGA for genital psoriasis later, you'll see that it actually goes to very severe. And sometimes there's actually pain with these plaques. There's even some erosive disease. And I'd be thinking about a wide differential and maybe even some comorbid contact dermatitis. Sometimes we have patients like this that have irritant dermatitis. You can get steroid atrophy that can lead to breakdown of the skin. I would be very concerned about particularly that patient on the right. Then you look at this gluteal cleft. I'm assuming it's either a gluteal cleft or it's a perineum, an area in between the genitals and the anus. It's a little hard for me to discern from the image, but since you pulled it, maybe you can give us some insight. But still, though, this is a good example of psoriasis in the gluteal cleft. We see that very shiny, white, thin scale, which usually I do find preserved in the gluteal cleft. Although anytime we see something shiny and white in the perineum, we always think about lichen sclerosis. But what's the giveaway for this being psoriasis and not LS is we don't see smaller papular lesions. We see a long, thin plaque that truly localizes to the crease and the crevice here. Overall, these are all great images for the listeners and viewers tonight to burn into their mind for genital psoriasis in multiple different manifestations.
Right. And to further complicate the matter, if we go back to that image on the right side, right, you see, arguably, one may say that you have like these scalped erosions with the scalp borders in some of the areas. And some of them may even look, quote unquote, knife-like, right? And so while it's not a perfect image for that, but I'm just trying to expand our differential here for the audience, right? Because these are things that may relate for like infectious disease, right? So in this case, like what we would be ruling out potentially, herpes simplex, right? If we have the scalp borders there. So it's really important also to maybe do, a viral swab or a PCR test or something like that. So keep that in the back of your mind, because even, let's say you also nail the psoriasis diagnosis, but you're not treating, let's say, an overlapping or super infection, you may not be able to actually to re-epithelialize as well. So you get a little bit complex with that, right?
That's such a good point. It reminds me of a case I had many years ago. It was a patient with pemphigus vulgaris and really severe, very severe oral involvement. And we put him on rituximab and immunosuppressed him. It seemed like the pemphigus was getting better. Then all of a sudden, he got these severe ulcers in his mouth, severe ulcers. And we were baffled. Why is his pemphigus not getting better? His desmogleins had downtrended. Things were looking good. It was a horrific HSV outbreak in his mouth because we had immunosuppressed the patient. And I think that's a very important call out, just like you said, to think about these infectious diseases, especially if you're putting topical immunomodulators in these areas.
Right. Yeah, fantastic. And going back to our quote unquote knife-like lesions, which again is not the perfect image, for our textbook followers, right? So do we, what does that buzzword associate with? Do you recall?
Well, there's a couple actually. So there's two. One you already hinted on, which is actually an HSV. You can have a knife cut lesion, but also cutaneous Crohn's can manifest with these knife cut lesions. And certainly patients with psoriasis are more likely to have inflammatory bowel disease. It's also true for our patients with hidradenitis, which becomes a very important screening question, especially if we're thinking about starting a systemic agent. We always need to ask our patients if they have a personal history of IBD, Crohn's, ulcerative colitis, or a strong family history. And for patients that don't have medical literacy that you or I do, Dr. Issa, I'll just explain to them, have you ever had bouts of inexplicable severe abdominal pain and or bloody diarrhea? And to me, that's enough to avoid an IL-17 inhibitor. And I'm planting that seed now because it's an important call out as we get into the treatment section down the line here.
Right. And, this think about cutaneous Crohn's, for example, right? While we may have that systemic Crohn's and IBD flavor, right? A lot of psoriasis patients may have comorbid inflammatory bowel disease, right? As you just said. So, but sometimes, it's going to be difficult from a cutaneous aspect in order to differentiate, right? So basically what I'm trying to get at is we may need to biopsy. This is the first time we used the word biopsy, and I may actually, bring that up at the first visit and say, look, this is not a slam dunk diagnosis, what's going on, right? And I may need to get a little bit of tissue. So I would keep that in the back of our minds and not be afraid, to go ahead and do a biopsy. And if you're not comfortable as a clinician in this particular circumstance, find a buddy who is and refer to them, because you may be doing a world of good by getting that biopsy done.
Yeah, I always say, in dermatology, tissue is the issue. It's easy to succeed where others have failed to biopsy. However, I have a third rule that trumps them all, and it's a little hydrocortisone goes a long way in the genitals before you cut someone's penis or their labia, because once you take that piece of skin, even if it's a small piece, you can't put it back. And I will tell you, if you're going to do a biopsy, you're much better off sinking a small punch in than doing a shave on the penis, just as an FYI from a healing and cosmesis standpoint.
Yes, actually. So that's a perfect segue. And maybe you can show us on the following images, like how you would walk us through that. So let's go ahead and move on here to the male perspective, right? So here, you can see the genitalia, and you can see on the crown and the glans penis at the image at the top, right? You can see a little bit of beefy red there. You can see some scale as well. And you can see, you don't see kissing lesions, right? That you see in classic Zuhn's balanitis, but you do see like that plaque extending all the way through, from the prepuce, to the corona and to the glands, as well as the shaft of the penis here. Any tips, say, if you were going to biopsy here, what would you do?
Well, first off, I'll say I wouldn't biopsy either of these patients, particularly at the first visit. I would start them on appropriate therapy, because I think these are good images, again, to burn in your mind for plaque psoriasis on the genitals. However, if I needed to do a penis biopsy on the patient's image on the top, I would tell you I would not biopsy the glands. I would biopsy the underside of the shaft of this man's penis, and I'd do a 3 millimeter punch, and I wouldn't even sink in a stitch. I'd spread the skin as far as I could, do a little shallow punch. You don't want to sink down into deeper tissues. You're just getting a little bit of skin. Be very, very careful, because you don't want to damage any other structures. But the reason why I would target that area and do it in that way is because the penis grows and shrinks. It changes a lot. And if you do the shaft itself and spread the skin on the underside, it's an area that guy is not going to be able to look at regularly. Any partners are not going to see regularly. But if you do a punch into the glands or along the corona or anywhere near the meatus, you might be in big trouble from a cosmetic standpoint down the line, even a 3 millimeter punch, which you don't even need a stitch to close.
No, that's fantastic. And just one more added pearl, not from a biopsy perspective, But one thing we didn't touch on from an infectious standpoint for our differential diagnosis is human papillomavirus, right? And while this does not look like human papillomavirus, right? That's not the point, but maybe history of HPV that may lead to penile intraepithelial neoplasia. So what I'm trying to say, it's important to ask as part of your history taking, right? To make sure that you're not missing a squamous carcinoma in these patients. And I say this because I had a case of this but that was on the scrotum that required Mohs. And that was a harrowing experience for the patient, right? As you can imagine. But, these are the little pearls that we have to keep in the back of our minds and ask about, as we were saying before. Wonderful. Okay. So enough of the morphology here. Let's go ahead and get into the psychology of these patients, right? And here are just some stats. As again, we've already talked about this quality of life burden. These patients have psychological comorbidities, including depression, anxiety, and interestingly, suicidal ideation. But I think that number is actually quite high and really surprised me. Over 1 out of 10 patients of having suicidal ideation, and this really tells us that I think we are underestimating just how bad these patients are being affected, right? So the psychosocial burden, and then that decreased frequency of intercourse, right? So about 4 out of 10 patients have that decreased frequency. The quality of life for that patient, as well as the patient's partner, right? The family life, right? It's going to really have a multifaceted effect, right? But any further comment besides this, David? I think it's pretty obvious.
No, you're absolutely right. The numbers speak for themselves. And I'd say if you're newer to derm or newer to this arena of dermatology and you find them incredulous, it's absolutely true. And I have so many stories, even from when I was a young dermatologist out on my own. And I think back to some of the first patients I treated with genital psoriasis and how life-changing it was for them. One woman with labial psoriasis had it for 25 years. Some gentlemen that had it on their penis for a number of years and hadn't had intercourse with his wife for 2 years. A young man, every time he got an erection, he had essentially a fissure and a crack, and it was painful to have intercourse. He's trying to go to college and live his best life and meet partners, and he's not able to even get an erection. And that's why I think that this 12.7% prevalence of suicidal ideation actually does track when you think about the severe quality of life impact it has. And it's easy to sit here and say, oh, decreased intercourse frequency in 43% of patients, that must be so terrible. Ha, 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 they're not having sex. But it's not about having sex. It's about the human connection. It's about self-validation and self-esteem. It's about feeling like you are a normal part of society that can do what humans are meant to do. And it just happens to be a very important and intimate way that we all connect with the rest of our species, and not being able to do that or feeling adequate enough to do that truly does drive feelings of depression, anxiety, and also, sadly, in this case, we see 1 out of 8 patients having suicidal ideation.
You hit the nail on the head. Thank you. Well, with the psychological severity, so how do we actually look at the assessment of severity for genital psoriasis in of itself? So interestingly enough, while genital psoriasis, we all have seen it as investigators in clinical trials, we have also seen it and assessed it most likely through the PASI scoring system, right? It's a part of the psoriasis area and severity index. It's a sub-score, right, that we can pull out. But in your experience, like we can see them on the table here, the different metrics. But you as an investigator as well, any call outs in terms of what our scoring systems have been? Like what do we see in the literature?
Well, my favorite call out here is just that the genital psoriasis PGA scale goes from 0 to 5. Mm-hmm. Because when you have psoriasis on your penis or your labia, severe isn't as bad as it can get. It can actually get very severe. And I think that's an important distinction, because even though that's how we grade it in clinical trials, it gives you a sense of, in your mind, a connotation of the severity of this disease globally for the patient's life, even though that's not what that metric is actually following. But it just reminds us that when you have psoriasis on your genitals, it can be very severe. So that's an important call out. Certainly we know about DLQI. I don't necessarily think about DLQI often for my psoriasis patients, so I do for other diseases. But I think that there are some specific questions on the DLQI that certainly do hit. There's questions about sexual frequency essentially on the DLQI that is important. But also just the genital psoriasis quality of life, even though that's not one that's widely used, it's a little more specific. And so for me, Dr. Issa, I think that probably those are the three that rise to the top of my mind.
Right, and I agree. But what's when you look at the literature, it's the endpoints and these metrics are so varied. And I think that's an important call out as well. As for those who like to study the literature, is that we haven't really made consensus approaches, to genital psoriasis. And hence we see in some major, some randomized trials, as we'll see, or observational studies or single observation prospective studies, what have you, that they're not the same. Right, each of them are using their own sort of metric, and while we may have, let's say, the genital, physician global assessment score, it is validated, but it's not just all widely used across psoriasis, trials as well. And interestingly, the last one, and I think this is a very important one on the list. There is the intertriginous investigator global assessment. This is a newly established validated metric, and honestly, it was really created when we were looking at the roflumilast study, the topical PDE4, which we'll look at that study in a moment. But it was made in that clinical trial, specifically looking at the intertriginous areas, and that's another milestone in terms of getting yet another validated metric for these investigator studies, right? And that's on a 0 to 4 scale. Likert scale, as we are familiar with, right? So I really think that the current unmet need, and maybe you agree or disagree with me, David, but I think the major unmet need is going to be that, we need some consistency. We need further consensus, as we move forward, with studying genital psoriasis. All right. So now we actually get into the targeted therapies, and some treatment strategies for genital psoriasis, probably what the audience has been waiting for all time, right? So for our traditional management, right? So classically, we do start with corticosteroids. And granted, we are now in an era of steroid stewardship, but a lot of folks are still initiating with a topical corticosteroid and classically with low potency, maybe mid potency, but we typically go with low potency because of that sensitive area, the thin skin, right? And we try to avoid skin atrophy and stria and telangiectasias. And some additional limitations with with corticosteroids is you may get tachyphylaxis. And David, what is tachyphylaxis for those in the audience who have not heard that term before?
Oh gosh, I always explain this one wrong, Dr. Issa, so correct me if I get it wrong, but I'm pretty sure that's where the disease recurs and gets worse and essentially rebounds despite continued use of the topical steroid. Did I get it right tonight?
Yeah, you nailed it. And another way of saying it, if you invert it, right, is saying that the drug that was working is no longer working, right? So it ran out of juice, right? So great. So tachyphylaxis, but we do see that with corticosteroids, quite frequently. So I think that's important as part of your counseling, that they may not, keep that response over time. And sometimes we have folks who are really super absorbers, and they may have HPA axis suppression with extensive use. So corticosteroids is one thing, and then what are some traditional topicals that we have used off-label? Because these are not FDA approved, but when we were in training, for example, what were we using?
Oh, we see our favorite workhorses up here from the old days: calcineurin inhibitors, tacrolimus and pimecrolimus. Been around for more than a quarter decade now, and certainly we use them broadly off-label. But the trouble with some of these medicines is they're not formulated ideally for any skin type, particularly sensitive skin. I don't mean sensitive emotionally, but I mean sensitive physically. Tacrolimus and pimecrolimus have a lot of propylene glycol in it. They sting, they burn. They sting and burn me when I put them on my skin. Even some of our other non-steroidal options not listed here for eczema, like crisaborole, also stings and burns when I use it, when my son uses it. And that's the last thing I want to put on a rash on a sensitive area for a patient like their penis or their labia. We see some vitamin D analogs. There's a lot of irritation with those, particularly the genital areas. And coal tar, Dr. Issa, I don't know if you've ever recommended a patient put coal tar on their skin for their psoriasis, let alone their genital skin. I've never actually used that in all of my years yet as a dermatologist. Have you?
Well, not personally, but there was once a magical place called the VA, or the Veteran Affairs, and so some of our sage professors who grew up with coal tar, may have recommended it. So I think it's important just to know that it once was used, right? As for holistic learning, right? But you're right. I certainly haven't, nor will I, for that matter. that takes things to a different realm. So now let's get into our non-steroidal options, right? And so here we bring front and center roflumilast 0.3% cream, right? So the 0.3% cream is what is approved by the FDA for plaque psoriasis. And as a quick call out, there are 3 formulations, right? And the other 2, which are 0.15% and 0.05%, are for atopic dermatitis. Then that's being used for children and adolescents, right?
And
so
of course, we don't want to forget about our 0.3% foam, which is also approved for plaque psoriasis as well.
That is correct. That is correct. And actually, more recently, we have a decrease in the age actually for approval for the roflumilast cream as well. And I believe off the top of my head, I think it's age 2 years, right? Unless I stand corrected.
You are correct. You hit the nail on the head. Age 2 and above for roflumilast cream for patients with psoriasis, and then the foam is approved down to age 12 for psoriasis, 9 for seborrheic dermatitis.
Excellent. Good. And mind you, we don't have our notes, guys. This is our heads. So as a brief background for the clinical trial here, this is the pivotal phase 3, Dermis 1, Dermis 2. You had these patients who were age 2 and up who had 2 to 20% body surface area in terms of plaque psoriasis on their body, right? So they had to have at least mild to moderate, and then they were randomized to vehicle or the roflumilast cream once per day, right? And this was an 8-week study, and then there was a long-term extension after that, just like any other study. But the interesting part here is when they are looking at the high impact sites or special areas or SAs, as you will. So in that middle figure, if you look at the top part, they're dividing out these patients who had their mild to moderate plaque psoriasis, all over the body, and if they had a special area that was affected. And they looked at their IGA scores, which is the holistic mark, across the board. And you see that regardless of where those patients were having that special area, in addition to their, say, truncal or extremities, what have you, they were all responding the same. So you see some consistency across these different morphologies for these patients. But the more important thing for tonight's discussion is that you have that other IIGA, right? That intertriginous IGA, which is going to be that figure 3B, on the bottom. And here for that is specific validated metric at the special site for the intertriginous, which includes both genital areas as well as, the intertriginous and the intergluteal areas. You have that there is superiority for the roflumilast cream, right, versus the vehicle cream.
What I noticed from this is that particularly in the intertriginous areas, roflumilast beats the spread, where it was tracking at about a 50% IGA clear, almost clear across the trial at 8 weeks. When we look specifically in special sites, it seems to perform even better. And that may be due to a variety of factors, including perhaps less thick plaques, et cetera. But certainly it seems to do extremely well in the intertriginous sites. And yes, Dr. Issa, I agree with you. In terms of seeing a dedicated study that looks specifically in a vehicle-controlled manner in intertriginous sites, I do agree with you.
Yes, it's unique on multiple levels, exactly as you just said, and that level of success being 70 to 80%, right, in such a short period of time. Is also, a milestone as well. And that correlates and tracks well with how these patients are rating their itch. Now, granted, you're not rating the itch to a specific area, right? We don't have those kind of metrics, but rather the global itch, the worst itch NRS scores. And you can see that these patients, irrespective of where their special area, including intertriginous and or genital, that they're still performing that even spread, as you said, with that 4-point improvement happening in at least 70% or more of patients. So what we're trying to say is that even with these tough to treat areas, which includes intertriginous and genital areas, roflumilast 0.3% cream performs exceedingly well, right? And you like to see that consistency. And as you said, we were going to talk about tapinarof cream, and here we are. And this is a different animal, right? So it's wonderful to see that we have these dedicated trials, for this problem, right? But here, this is different. This is not a phase 3. We're looking at a phase 4 open label study here. So this has about 34 patients, and these are looking at adult patients age 18 and up that have a specific, genital psoriasis severity score of 2 or more, right? And these patients have minimal outside body surface area involvement as well. But everybody was on medication, right? So this is the aspect of open label, and this is a 12-week study, and the treatment endpoint was to get to clear or almost clear. And we see, as expected over time, that patients are achieving that clearance score. And you can see at the top right that for achieving a score of 0 or complete clearance by 12 weeks, that 65% of these patients were able to get there, and people's itch score was improving pretty rapidly in those intertriginous sites. So yet another non-steroidal success, but a different clinical trial design. And then, David, to round out, our journey with genital psoriasis, as we talked about topical treatments. Now, just briefly, a segment on biologic and systemic therapy. There has been a lot of movement in this space, but the clear thing to note here is that very few randomized blinded placebo-controlled studies have been done, and we've listed them here on the left side of the screen. It includes apremilast, ixekizumab, guselkumab, and the more recent oral IL-23 receptor blocker icotrokinra. And for those of you who are interested, we have listed the studies here on the left side of the screen. But we also have a lot of retrospective as well as observational studies for pretty much all the biologics that are currently on the market on the right side, both in the US as well as abroad.
Yeah, there's a lot happening in this space, and it's hard to even keep up with it in real time. There's even risankizumab has published their phase 4 trial, randomized double-blind placebo-controlled phase 4 studies for Riza versus placebo in genital psoriasis. The bottom line is, if your patient has psoriasis of their genitals and you think they need a systemic, it's always great to use clinical trial data to guide you. And fortunately, now we have a number of molecules that have been investigated in this specific manner, and they all seem to work pretty well across the board. Well, Dr. Issa, now that we've spent some time talking about the disease burden, how it impacts our patients, and a little bit of the treatment landscape, I think it'd be nice to wrap up with a case presentation. And this is a beautifully outlined case. I wonder who put it together, Dr. Issa. It looks really good. It's a 38-year-old woman with a 6-year history of moderate plaque psoriasis, BSA 12%, DLQI 14. She's presenting with a new rash in a sensitive area that she was embarrassed to bring up sooner. She notes significant burning, itch, and pain during intercourse for the past 18 months. She uses fluocinolone cream intermittently with temporary relief, but increasing skin sensitivity. She reports avoidance of intimacy and worsening depression. Her PHQ-9 score at her visit with us today is 13, putting her in a category of moderate depression. Her full body exam reveals well-demarcated, non-scaly erythematous plaques in the labia majora and inguinal folds consistent with genital psoriasis. Her genital IGA or PGA is 3. We've talked a little bit about the assessment already. How would you approach this patient from a discussion standpoint, Dr. Issa?
So to make this really an efficient kind of discussion is that you have to identify this is a patient who's suffering, right? We looked at her depressive aspect to it, and the fact that she's using a topical steroid for some time, right? So now we have to practice some steroid stewardship. We have to have that discussion and try to move away from the steroid for a more long-term control, right? And that we need to have this plan so that she can regain that quality of life back, right? So we should acknowledge that this has an emotional impact to her, discuss the limitations of steroids, talk about the non-steroidal options for her, and in this case we initiated the roflumilast 0.3% cream for her genital plaques, right? And also advised for a fragrance-free emollient, which is great. You should always be moisturizing for these patients. And we continue to ask her over time with her follow-up visits, right? How does she feel, right? So some of us like to do a PHQ-9, not everybody does, but some of us like to document that as well. So we ask her, how she's doing, and her quality of life has improved. And if she was not improving with the topical, right, then we may want to get into the arena of using biologics and systemics there. So, move away from steroids. Always continuously ask how the patient is doing. And if they're not where they need to be, don't be afraid to escalate care to the systemic world.
I'd like to tip my hat to you, Dr. Issa, for this case. And for anyone listening, this is Dr. Issa's case, and it's a great example of comprehensive psoriatic care. It's not just about giving them another cream, moving the ball downfield. He's addressing the mental health component. He has a plan for appropriate follow-up at a reasonable interval to see how she's improving. And he's already planning what his next option may be at a systemic level if she hasn't improved to his or her satisfaction. And he's reaching for a specific biologic that's been studied in this arena. Just chef's kiss to you, Doc. I'll always bring excellent level care, and this clinical case is fantastic.
Thank you. And before we wrap up, I think what is really important to add to this is one should have an algorithm for themselves, right? Whether you're using somebody else's algorithm or creating yourself, but always have a plan, right? And then when it's that you don't have a plan for a step B or a step C, your patients may lose confidence in you. So always have that. It's okay, you have it written down to refer to as well. It's just a good strategy for good medicine. And with that, Dr. Cotter, right, I would like to really thank you for taking the time this evening to go on this wonderful journey of, this high impact and hidden impact genital psoriasis journey, right? As a quick recap, right, genital psoriasis is affecting a majority of patients, anywhere of 1/3 to 2/3 of these psoriatic patients. We really need to, bring this to the fore and ask our patients about this, right? Make them feel comfortable. And you may not have a large body surface area, right? You may have a high impact disease burden in that, less than 1 to 2% body surface area involvement. And the Academy also, mentions that in the National Psoriasis Foundation. We should always be proactive and try to at least offer full body examinations and sensitive site examinations for the patients, make them feel comfortable, acknowledge their psychosocial burden, right? And not only acknowledge, but also give them confidence that with treatment that they will get better in multiple aspects of their skin as well as their mental health. And never forget, right? We have now non-steroidal topical options as well as systemic medications and biologics, right? We should not be fixated and stuck on steroids, right? This is a new era with great medicines, that we currently have as well as on the horizon, right? So let's not forget that. Any parting words, Dr. Cotter?
I couldn't have said it better. Thanks for putting together these beautiful slides, Dr. Issa. This was a fantastic lecture.
And thanks for being here with us. And thank you all for joining us. We hope you learned something in the last 45 minutes or so. See you next time.
Please visit www.livederm.org for more dermatology education.
Well, I hope you guys enjoyed that. I really found that fascinating. In private practice, I can tell you that we don't have too many patients that have ever come to urology complaining of the genital psoriasis. Often we notice it when we go to do things like catheter changes, taking stents out, etc. And that's a good time to maybe approach and say, hey, is that really bothering you? Maybe we go see a dermatologist for the latest treatments, because those guys are the ones that are on top of all these biologicals. So definitely one of those things. I think it's way, way under reported and undertreated, and why not seek out a treatment if you need it? So, and for those patients that are out there watching, it's embarrassing to you. It's not embarrassing to us. We understand it's embarrassing, but seek out treatment because that's important. Hey, next week coming up on
Welcome to Uro Nurse, hosted by Vic Senese, where healthcare professionals and patients discover the latest innovations transforming urology. In this exclusive interview, Vic is joined by Dr. Diane Newman, Chief Clinical Officer, and Dr. Stuart Hart, Founder and CEO, to introduce UrologyHealth.com, the first virtual urology practice, a groundbreaking digital health platform created by urology experts and backed by more than 50 years of medical science. As healthcare continues to evolve, virtual care is becoming an essential part of delivering accessible, evidence-based medical services. In this conversation, you'll learn how UrologyHealth.com is designed to connect patients with expert urologic care through innovative digital technology while maintaining high clinical standards. Join us on August 22nd at 9 a.m. Central Time to learn more.
If you haven't heard Diane Newman speak, you don't want to miss it. Diane Newman is part of the founding of this, along with Dr. Stewart, for this online virtual-based treatment for urology for female patients. They're hoping to move it into the male realm soon, but they introduced this thing, and I talked to Diane and said, hey, you really ought to talk to us about it more. And have your questions ready, because it's going to be a great presentation. We'll have them on our show next week. And for those of you that are still burdened with these storms and don't have power or whatever you're doing, hey, I know it's been a long journey. It hasn't been fun, but we're all alive. That's the most important thing. So hang in there, and we'll see everybody next.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.